we need to penetrate this image from. Again, in the normal phased array probes, we have the line of elements that are providing us with wide field of view. We also have matrix array 2D probes, which give us elevation focusing. However, we had to wait till the development of the matrix array with 40, 50, 60, 80 rows, as well as columns of elements, providing us with a pyramid-shaped volumic field of view up to 90 degrees by 90 degrees pyramid type of image originating from the tip, which is the surface of the probe. However, because of the large number of elements, unlike the normal 2D probes, the matrix array probes they would have traditionally between 2,000 to 3,000 or 4,000 elements. Now, in the latest probes, we have more than or almost 6,000 elements. That means on a 3,000 element probe, that means you need to have 3,000 wires going in, 3,000 wires going out, sending and receiving the signal. And that would mean the cable would be large enough cable similar to the ones that will power a city, you know, in terms of number of wires. So this is why we actually, in the 4D probes, there's always some sort of processing that happens in the probes themselves. This is why the early probes used to be very bulky, because they used to have somewhere in the vicinity of 6 or 8 circuit boards, multi-layer circuit boards, in order to be able to do a little bit of the multiplexing in terms of electronics, we call it, that will enable us to process this much data coming from this huge number of elements on the probes. Then we ended up using more advanced processing or signal processing, using the advancements on or the miniaturization advancements in technology, such as now, as you know, in our smartphones, we have CPUs that are as big as the SIM card on our mobile. And this is what we are using actually in these probes. We have, for example, evolved the probes from the huge bulky probes in the past now to even higher number of elements with smaller size and smaller footprint and even smaller weight than the 2D probes. And thanks to these microchip, again, CPUs that are mounted right below the surface of the matrix probe, that enable us to process this much data, having such 4D probes, such high number of elements, such as in this probe, at the same size and even weight of the normal 2D probe, and of course, most importantly, the cable, which is normal size. And this applies to transthoracic probes as well as transesophageal probes. As you know, in the old TE probes, we used to have a disc. This disc is tied to wires that will rotate the disc, because the disc has only one line of elements, which is giving us one plane, and this plane rotates as we do the manual or the electronic rotation, but it's still one disc that rotates. Now we have the matrix array, where we electronically switch any of the lines in order to produce any plane, in terms of using it as a 2D probe in a multiplane, and also switching all the elements at the same time, providing a pyramid shaped, again, volume acquisition using these 4D probes. The result is, of course, uniform probe solution for pediatric, for adult, for example, as well as TE probes. So now that you have the TE probe and you start scanning, for example, transthoracic, of course, in TE, there's no difference in the windows, but we'll talk about that also here. But in terms of transthoracic for the echo, are the windows and the views different in TE than, for example, normal 2D scanning? The windows are the same. However, keep in mind the requirements are a bit different. How is it different? For example, if you are in the parasternal, or let's say if you are in the apical view and you are scanning the 4-chamber view, then you position the probe in an angle that is between, for example, 2 o'clock and 8 o'clock. And all you need is enough intercostal space to slide this plane through this window. So keep in mind that for 4D, you actually have an elevation height of this window that also needs to be done, because you need to get the z-axis, or in other words, the elevation plane of the image, and that means your window has to be even bigger and wider. This is why we always say, when you are doing 4D echo, it is even more important to have the right kind of bed, hopefully the cutout bed, to have the right position of the patient. Always connect ECG so that you can get the right 4D data for the volume acquisition. So 4D scanning or 4D echo is not easier than scanning 2D. However, it will give you more information once you do the acquisition. So the requirements, it is more critical to get the right data sets. So now that we have a 4D probe, we are scanning in the 4D probe. The first thing that you can do with it, of course, is the normal 2D scanning. You can do 2D color Doppler, pulse wave, continuous wave, M mode. You can do everything that you can do with the 2D probe. And that is simply by powering or by switching on only one row of the elements. And then you get, for example, the long axis, you rotate the probe and so forth to get the other views. However, there's something which is called multi-dimension imaging, which where we have also, for example, biplane. And with biplane, we are able to have the original plane and then another plane perpendicular to that plane, which is the short axis. So for example, if you start with the parasternal long axis view and you click on multi-dimensional imaging on the machine, on the Vivid, for example, you'll have the button that says multi-D, and then you'll have a selection between biplane and triplane. Of course, in parasternal positions, the best view is the biplane. Hence, from the initial plane, the parasternal long axis, you'll have a dotted line indicating where the short axis will be. As you can see in this example, the short axis is taken at the papillary muscle level because the dotted line here falls exactly at the papillary muscle level. And you can move the dotted line. You can also rotate the planes so you can get a not so perfect short axis as well. You can even do automatic 30 or 60 degrees rotation at one step, because again, you are switching all different diagonal lines of elements in order to produce that other plane. So you can see here the original plane, the yellow plane, which is the parasternal long axis. The short axis is the white plane, and again, it falls under the dotted line where it's perpendicular to the long axis. It is at the point of the dotted line. Then, in addition to having biplane, we are also able to select triplane. And in case you are using a Vivid E95, for example, on the touch screen, you can click on triplane. Once you activate multi-D, you have the option to click triplane. And this is especially exceptionally useful in apical views, because in apical view, if you start with 4-chamber, usually, from 2D scanning at 60 degrees, you can have the 2-chamber, at another 60 degrees, you can have the 3-chamber view. In other words, you'll have 3 apical views simultaneously without having to move the probe from the original apical position. So all you have to do is go to the 4-chamber view in normal 2D scanning, and then you click on multi-D, select triplane imaging. Immediately, you'll have these 3 apical views simultaneously. Now, if you've tried this before, chances are you will not always get the ideal 4-chamber, 2-chamber, 3-chamber simultaneously. There is a trick. First of all, you have to make sure that your LV is not foreshortened. You have the longest apex on top and in the center. And also, unlike the traditional 4-chamber view where we tend to keep the septum in the middle, don't forget that these 2 other planes cross the original yellow plane in the center of the image. In other words, the center of your image has to be the LV and not the septum. So you try to move to the septum to the left. As a result, once you activate triplane, immediately you will get a perfect 4-chamber, perfect 2-chamber, and perfect 3-chamber. And this is ideal because we are acquiring all these 3 planes simultaneously. You are seeing them live simultaneously. And when you store, they will all be stored from the same ECG cycle. Why is this important? Especially if there's any cases of arrhythmia or RR variability, then you can do all kinds of quantifications, such as ejection fraction biplane, Simpson biplane, for example, whether you do it manual or the auto AF Simpson biplane, or if you are doing also triplane ejection fraction from triplane. This is using the Simpson, the Auto EF Simpson biplane, which also uses speckle tracking. We'll talk about that in a little. You can also do triplane ejection fraction because Simpson uses the diameters of the LV from the 4-chamber as well as the 2-chamber. But here with triplane EF, we are using also one more diameter to get a better information or better idea about the geometric shape of the LV in diastole and likewise in systole, and hence getting even more robust data to get the overall volume of the LV in diastole and in systole using this triplane method, which also I will show you. But again, the most important thing, start with a properly open, not foreshortened LV. Because remember, in triplane imaging, you are actually scanning 2D planes. We are not scanning the full volume. As you can see here, when we rotate the image a little bit towards the apex, there is nothing in between these planes because we are only acquiring these planes. So they have to be proper planes. They cannot be foreshortened if you want to get accurate measurement, whether it's ejection fraction or even if you're doing strain imaging as well. And this takes us to the next step. So to explain first of all, strain imaging or how it works. What is strain is based on speckle tracking or 2D, what we call 2D speckle tracking. And just to explain this, what is speckle? Speckle is simply a group of pixels that have a specific shape that can be recognized by the algorithm, by the speckle tracking algorithm. And this group of pixels is called speckle, right? And this speckle in this frame, in this image, this speckle is recognized here. What happens next frame, the algorithm tries to look for the speckle, but it doesn't find it. It finds that it has moved. It finds the speckle, but it has moved. So it can calculate the distance, and from the internal clock, it knows the time. So distance divided by time equal velocity. This is the first Newton law of physics, of course. And the unique thing here is, unlike tissue Doppler, where I can detect velocities towards or away from the apex only, here we detect any velocities, even lateral components, and even the angle, the actual angle of the velocity. As a result, we can get better or less, let's say, less angle-dependent velocities and strain quantification using speckle tracking than we do with tissue Doppler, despite the lower sample rate, which is the frame rate of the 2D imaging, but we can still get better, more accurate velocities and strain curves than with tissue Doppler. Because here, for example, this yellow segment, this basal inferior wall segment, as you can see, is angled almost at 30 or 40 degrees from the beam of the line. So in other words, if you're relying on tissue Doppler, you will get a lateral component mixed with longitudinal component. As you know, longitudinal strain is different than lateral strain. They're actually opposite in terms of during systole. So this is why speckle tracking can be more reliable in getting the accurate curves. So what we do, we use speckle tracking for the 3 apical views: 4-chamber, 2-chamber, 3-chamber. You can see the region of interest and the segmentation automatically done. And of course, as a result, we get the bullseye of all 18 segments simultaneously. And even the curves, the strain curve for each segment, you can see the systolic strain, all segments, normal patient longitudinal strain should be around minus 20. And then it goes back to near 5 during diastole or early diastole, and then diastasis, and then with atrial contraction again, it defaults down to 0. If you from the curves, of course, as you know, in strain from the curves, you can tell if this is a post-systolic shortening or if there's only a phase shift or a phase delay, as in asynchrony or ischemic cases, as in this graph. But that's a different topic altogether. What matters here is that with triplane, I am able, with the 4D probe, I am able to acquire 4-chamber, 2-chamber, and 3-chamber simultaneously from the same ECG cycle without the frame without the heart rate variability risk, and of course also without severe difference in the frame rates, because also the frame rate have to be similar between these three views. Otherwise, AFI or the strain algorithm will not accept it, simply because it has to have the same sample rate in order for the data to be robust. And we get ultimately, we get the bullseye of the 18 segments or the modified 17 segments as per ASE requirements of the peak longitudinal systolic strain, and of course the ultimate value, which is the GLS, the global longitudinal strain, which is again the average of all 18 segments. And again, the advantage here is that we are acquiring all at the same heart cycle, the same heart rate, the same frame rate. So this is also very helpful when it comes to peak strain dispersion or the time to peak strain, because again, if you are acquiring all three from the same cycle, from the same aura, so you have the same QRS beginning of the cycle, you have the same end systolic value, so you also have the same time measurement from time to peak. So if you see a difference in time, as in this case, it will be real. It's not due to some changes or the offset on the QRS of the ECG. So again, here you can calculate with more confidence peak strain dispersion, as in this case 116 milliseconds, indicating that this is a true intraventricular asynchrony, as in this case you can see these walls hitting the time to peak strain 260 to 280 milliseconds after QRS. These here reaching their peak at 460. So the difference is almost between these segments and these segments, almost 200 milliseconds. Huge time difference. Likewise for myocardial work, because with myocardial work, of course, we take into consideration the resistance, which is the blood pressure. So we calculate the instantaneous or we calculate the product, the actual work, which is strain multiplied by blood pressure. And of course, this is very important when you have it from the same, all the segments from the same ECG cycle, because it will give you the constructive versus wasted work for each segment versus global. And again, this is very important when the timing is very important in that aspect. In addition, a triplane has one more huge advantage, is AFI stress, where we are able to acquire all three apical views, hence all 18 segments, instantly for each stage. So for example, you can do a four-stage dopamine stress echo without ever having to move the probe. Just put the probe in the apex, get triplane for baseline, triplane for low dose, triplane for peak, and triplane for recovery. And eventually you don't even have to do wall scoring. You can just apply AFI for each stage. You can get a different bullseye for each stage, so you can compare the baseline bullseye with the low dose and the peak bullseye, whether you are assessing a viability study or actual stenosis or perfusion. Then you can see compare between baseline and the peak systolic strain. Again, never having to do wall scoring really, because AFI will give you the similar type of information, because it gives you the longitudinal strain for each segment in baseline and low dose, peak, and recovery. Likewise, we can also utilize whatever acquired in 4-chamber. We can also do AFI for RV. We can also do biplane imaging for 4-chamber and 2-chamber. So again, RV strain has now become a huge, an important value in assessing RV function, especially with the COVID pandemic and with the myocarditis happening in RV and pulmonary embolism happening in lots of COVID patients. Then there's AFI for left atrium, where we can also do biplane on 4-chamber, 2-chamber, with, of course, focusing the images more towards the LA to open the LA to the maximum height of the roof of the LA and the maximum width, of course, of the LA. And then we can also do strain for LA from 4-chamber, from 2-chamber. We'll get reservoir strain, conduit strain, as well as contraction strain, atrial contraction strain. Of course, this is longitudinal strain. We get it from 4-chamber, 2-chamber, and the biplane. Even the volume and the ejection fraction of the LA can be calculated using this algorithm automatically. It's called AFI left atrium. So all this without even doing volume imaging, just doing multi-dimensional imaging, biplane and triplane. Then let's go talk about 4D volume acquisition. In 4D volume acquisition, we have two ways of doing it, or acquiring the full volume. You can do it with single beat or multi-beat. What is the difference? This question that always comes up. What is the difference? Which one's better for acquisition? The difference is that with single beat, we acquire the full volume every cycle at a certain volume rate, usually because we are acquiring a much bigger volume. It compromises the volume rate. We cannot do the acquisition that fast, and it compromises also the spatial resolution or the voxel resolution. However, we are acquiring live when it comes to single beat. So, and of course, this was a limitation in the past. Machines were not capable of acquiring single beat. Now, all machines or all advanced machines, let's say, are capable of acquiring single beat. So how does multi-beat work? Multi-beat, we acquire one section, the first cycle, another section, the next ECG cycle, another section, the third ECG cycle. So as in this example, here you have the difference between, this is single beat, multi-beat. What we do here, the first cycle, we acquire the green section. The second cycle, we acquire the purple section. The third cycle, we acquire the blue section. Or we can also do 4-beat acquisition or 6-beat acquisition. That means we have to wait 4 cycles in order for the full acquisition, or 6 cycles in order for the full acquisition to happen. However, multi-beat has a unique advantage, is that because I'm focusing only on this small section on each cycle, that means I'll get much better the spatial resolution and much higher temporal resolution. In other words, my resolution, my axial resolution is better, or voxel resolution is better, and my frame rate is much better. Okay. So why don't we use multi-beat all the time? For these 2 reasons. First, we have to wait until we acquire it all. Second, the risk of stitching artifact. What does stitching artifact come from? From having different shift of the position between one beat and another. What are the causes of stitching artifact? Of course, motion is one of them, and the number 2 is arrhythmia. What are the causes of motion? Our hand motion, of course, if we're not keeping a steady hand during the acquisition between one beat and another. Second, the patient movement. And third, of course, the respiration, because when the patient breathes, then that causes also the heart to move, and even the window to change, and even the wall to change position. And of course, the other cause is arrhythmia. If you have difference in time phase between systole and diastole from one section to another, and that is usually caused by huge variation RR cycle. In other words, if you have bigeminies, trigeminies, and if you have PVCs, for example, before or after, or one of the cycles, as well as AFib. Despite the fact that most people tell you AFib does not really cause a huge RR variability, so you can even scan patients with AFib with multi-beat, as long as there's not a huge R to R variability. So the biggest enemy usually is bigeminies or triplets, and also if you have PVCs somewhere within the frame. Okay, so this is how a single beat looks like. How do you know if it's a single beat or multi-beat? You can tell from the ECG here. You can tell from the triggering. So there's only one ECG cycle. That means this was a single beat acquisition. Despite of it, you have a full volume of the LV and the RV, and acquired at a very nice volumic resolution. The frame rate looks nice, despite I don't see it here. But the frame rate looks all right. Yeah. Nevertheless, if we are scanning a huge volume, we always try to acquire multi-beat. the question is it better to acquire multi-beat or single beat? If you can acquire multi-beat, it's always better to acquire multi-beat because you're guaranteed a much better volume rate as well as spatial resolution. For color Doppler, it's always better to try to acquire single beat, simply because the color jet may vary from one cycle to another. And this, if you're looking at the jet in general, then that might be a good reason to use a single beat. If you are looking, as in this case, at a regurgitant orifice, then it might be worth it to acquire multi-beat if you want to also acquire it accurately. Okay, then I spoke earlier about multi-slice. What is multi-slice, and what can we use it for, and what is it the most beneficial for? Multi-slice is just a different way of looking at the volume. In 4D in general, we look at what we call surface rendering. In other words, here we look at the different surface of the tissue, and of course the blood is black. There's no reflection from the blood in ultrasound, so or from fluids. So that's why we look at surface rendering of the tissue in terms of the 4D volume acquisition. Of course, we have to crop somewhere in order to visualize better. That's the next topic. But what we can also do, instead of volume surface rendering visualization, we can look at what we call multi-slice. Multi-slice is CT-like slicing, where we are able to see, for example, the 3 apical views simultaneously, as well as 9 short axis views simultaneously with what we call a 12 slice view. How is this helpful? One, we can look at the function of the LV from apical segments. These are this is the apical ring, apical segments, basal mid segments, sorry, and then basal segments as well. We can also look at the anatomy and structure of from 4-chamber perspective, 2-chamber and 3-chamber. We can also change the level of the slices. You can see here this yellow line indicates this is where the short axis in the yellow plane or the yellow box is taken, and the green line, this is where the short axis of this green box is taken, and the other 7 are equidistant between the two, most apical and most basal. However, if we just move this top line using our trackball or mouse, move it down right above the mitral valve and move the green line below the mitral valve and angulate so that we capture the anterior leaflet. As you can see here in this example, we angulated this yellow line to get the to capture the tip of the anterior leaflet and the tip of the posterior leaflet from the 4-chamber. The commissures also from the 2-chamber. Again, the tips of the leaflets from the 3-chamber. Then we are guaranteed to have a perfect short axis at the level of the leaflet tip of the mitral valve, as well as near as possible to the commissures. That is perfect for measuring mitral valve area planimetry, because we know that we are not capturing an oblique section, which will always, any oblique section of the mitral valve area will always overestimate the mitral valve area. So, and of course, this is even more critical if there is an actual stenosis. Here, this is a normal patient, but again, this is where this tool can be helpful in assessing or capturing the mitral valve area planimetry. Another thing to keep in mind when you are in real life scanning, and you can see here from the ECG and the triggering, this is a multi-beat, this is a 6-beat acquisition of the full volume. But you can see in these short axes, there is no stitching artifact. And this is a unique thing about multi-slice, is that you can detect very well, you can easily spot if there's any stitching artifact during the acquisition. So before you waste your time and effort and keep storing all these loops, you can always double check the quality by using multi-slice, and then you can go back, once you acquire, then you can go back to surface rendering acquisition. So this is a nice way of checking the quality of the acquisition even before you store. In addition to checking for stitching artifacts, you can see here all the rings of the mitral of the LV from apex all the way to the basal. So you are sure that you are capturing the lateral wall of the LV, you're capturing the anterior segments and the posterior segments, and of course the septum all around, all through. So you know this is a perfect data set for any kind of LV quantification, whether it's LV volume, strain, or whatever. If you are doing the acquisition for RV, again, you can check the crescents of the RV from basal all the way to the apex. For example, this is an ideal acquisition for LV, so you can do LV volume, LV strain easily on this data set. However, it's not ideal for RV. Despite we captured the inflow, the outflow of the RVOT, of course, the anterior junction between LV and RV, the posterior junction, also the RV free wall, but only in the basal segments. As we go to the apex, the RV is lost. You can see here that the RV lateral wall, the RV anterior segments are out of the field of view. This is why this is not an ideal data set for RV. So again, multi-slice is very helpful in assessing, do I have the right volume for the purpose that I'm trying to do, because it's very important to have preemptively know what you are acquiring this 4D volume for. Okay, so in addition to once you acquire the volume, you are able to do automatic cropping with 4D auto views, what we call 4D views. This is a button that's on the machine. You click on 4D views. You do the auto align, as you can see here. You can do the manual aligning, or you can do the auto align. You can see here the annulus will be adjusted along the purple line for all 3 apical views, and the white line will cross the middle of the LV in each of the views. Before the auto align, it was not in the middle of the views. It was not in the middle of the LV from 4 chamber and 2 chamber as well as 3 chamber. Notice how the 3 chamber opens up, the aortic outflow opens up very nicely. The LVOT very nicely once we do the auto align. This is helpful because the machine has already marked landmarks internally in the data set where the cross section of the 4 chamber, where the cross section of the 2 chamber or the 3 chamber, and then you just by pressing one button you can just crop and rotate automatically from different crop planes of the same volume data set. This is the same volume, just I'm cropping it from different positions that are the conventional familiar 2D positions of 4 chamber, 2 chamber, apical long axis. This is cropping around mitral valve, so you're looking in face at the mitral valve. Flip crop enable us to look at it from the other way, and again we'll see that in practice in a couple of minutes. Then there's also additional cropping that we can do. Here, this is a nice way of representing a 4D volume data set. And again, because this is a 4D volume, and here you have the slice planes, the cut planes within 2D. These are reference planes. These are what we call reference planes. But my 4D data set is this one. This is the volume data set. And when you look at it from outside, you are looking at it from outside the LV. So you're looking at, from surface rendering perspective, we are looking at the outside walls of the LV. In other words, we are looking from the surface from the outside. We don't see inside. We need to be inside in order to crop inside. And this is where 2-click crop comes in. We decide our starting point and our end point of our crop, of how we want to crop this data set. So we decide we start from here to here. As a result, we have a perfect end fossa of the mitral valve, starting from the atrium, in other words, from the surgical view, looking into the ventricle. And we can see here, this is the anterior leaflet, this is posterior leaflet, this is the aorta, right? Looking at the mitral valve, again, in fossa from the atrial position. But if I start another 2-click crop, starting from here, then moving it forward to here, then you can see, again, in fossa of the mitral valve, but from the ventricular side. Now I'm looking at the mitral valve from the ventricular side, as you can see it opening and closing. This is the mitral valve. This is actually now the anterior leaflet. This is the posterior leaflet, and this is LVOT here. And you can see that if you start rotating the view. Then we can even look in fossa at the septum. So now we can see if there's any VSD by pointing from inside the LV towards the septum. Because here we cannot see the septum because we are outside the LV, so we don't see the septum. So again, 2-click crop is a very easy way to quickly decide from where to where I want to look at this volume data set. In addition to cropping, what we can do, we can actually acquire the volume in a perfect cropping shape from the beginning, and that is what we call 4D zoom prepare or flexi zoom. For the zoom prepare, we start, for example, here, and despite this is a TE acquisition, but we have the 4-chamber view, right? And from the 4-chamber, we click on the button on the screen, which is called 4D zoom prepare. This is from 2D without going to 4D, before we go to 4D. We click on 4D zoom prepare, then we'll get the original plane, which is the 4-chamber view, and we'll get another perpendicular 90 degrees perpendicular plane, which is between 2-chamber and 3-chamber. What this helps is it helps us decide where is my area of interest, where is my region of 4D zoom prepare that I want to do. And in this case, we're focusing on the mitral valve. So what we do, we get a zoom box, which is the original 4-chamber on the left, then the other 90 degrees perpendicular plane to capture the elevation, how much thickness we want to capture, as in this example. For example, here, I would have made this a little bit bigger to include more of the aorta, okay? Then we click acquire, or we click 4D. From that moment, we immediately get a cropped volume acquisition dedicated for that area of interest. In other words, we don't acquire the full volume and then start zooming or cropping. No, we acquire the zoomed acquisition from the beginning. This is what we call 4D zoom prepare. Why? Because all the processing is done only for that area, small area of interest. As a result, we get a much better resolution and frame rate. You can see the resolution is ideal here. This is in-fasa crop of the mitral valve, so I don't even have to do any cropping or rotation or manipulation anymore. We are using single beat, optimal resolution, and frame rate is very high, 13.3 frames per second. So this is called 4D zoom prepare or flexi zoom. Then we have another tool which is called flexi views, and this is, instead of doing these steps manually, just by starting from that 4-chamber or a long axis view, we simply click mitral valve 4D zoom. Automatically, the machine will give us a cropped zoom and start acquiring 4D for that cropped zoom just by clicking that one button. The same thing if I want to do it with color, for example, or if I want to capture aortic valve 4D zoom, or for aortic valve with color, or if I want to look at left atrial appendage 4D zoom, or if I'm in bicaval view. Of course, to capture the ideal LAA, I have to start with a 2-chamber view. In the field of view. If I want to capture the perfect aortic valve, I have to start with a 3-chamber view or long axis view, or midesophageal long axis view. If I want to capture the perfect intraatrial septum, in-fasa of the intraatrial septum, I have to start with a bicaval view. Then I click intraatrial septum 4D zoom, and then I'll get the perfect bicaval view. We can even program our own automated zoom crops by configuring new zooms anyway we want, depending on the imaging that we do. If you're doing pediatric, there's more options. If you're doing subcostal, for example, then the views are different. If you're doing suprasternal as well. So again, you can add additional cropping volumes. Laser lines also will show you where these reference planes are taken on the 4D, just to give us a better reference of the data set. Then there's an option which is called Flexi Slice. Flexi Slice takes us backwards. From the 4D volume, we can acquire, for example, a coronal plane that we couldn't, a 2D plane that we couldn't acquire normal 2D scanning. In this example, we are looking at a left atrial appendage. This is an in-fasa of the left atrial appendage. However, now I want to capture the neck of the appendage in short axis. Now notice when I started adjusting this plane here, I'm getting a perfect long axis and a perfect short axis. However, at this stage here, we have a perfect short axis aligning from this plane of the neck of the appendage. However, look here at this yellow line, dotted line. It's not perpendicular short axis at this appendage. It is actually almost 40 degrees angled. In other words, if I try to do the measurements here for this appendage, I will overestimate the length of this appendage. Now, when we adjust this plane, rotating it, that we get a perfect short axis. Now I can get more accurate measurements of the left atrial appendage, smallest diameter and largest diameter. The largest diameter would have been much overestimated if I did the measurement without making this perfect, because we have to align in one plane and then the other plane in order to get the short coronal plane of the neck of the appendage for the ideal plane for sizing. And again, if you do this here, this is wrong. This is why once we make the adjustment, then the length is much smaller. And again, my sizing dimensions are much better now that using FlexiSlice. FlexiSlice has also become standard, for example, when introducing mitral valve clips or even tricuspid valve clips by the protocol of the most of the cardiac societies, as well as the manufacturers of such devices. As you can see in their protocol, you have to use FlexiSlice in order to get long axis as well as short axis views simultaneously. We can also use FlexiSlice, for example, for aortic valve area planimetry, because again, you can align from one position the typical long axis, but also you can align in the coronal plane of the aortic valve to get the best slice to measure aortic valve area planimetry. You can also use it for mitral valve, just like we did with multi-slice. It's actually now as per ESCVI standard to measure, for example, a regurgitant orifice in the case of mitral valve. Because, for example, here in this anatomy, if you try PISA using this image, using this cut plane, you will get 0.7 square centimeter regurgitant orifice area, which is this red circle. If you try it on this cut plane on the same patient, you will get 2.7 regurgitant orifice area, which is the blue circle as per PISA calculations or measurements. But the real area is actually this one here, which can be easily traced using FlexiSlice, capturing the best angle of capturing this entire regurgitant orifice, which is a long strip rather than a round, small or large shape. We can also do 4D markers, where you can place a marker for the aorta. You can place a marker here. You can see this is in red, a flail leaflet. This way, when you start cropping and rotating, you will never lose perspective of where you are. Even from the 2D cut planes, you will also see where these markers are. However, look at this surface rendering, the way we are visualizing this surface. Again, remember in 3D, yes, we are looking at a 3D volume, and we are doing surface rendering of a 3D volume shape. However, we are displaying it on a 2D monitor. So something has to tell me the depth perception, which one is near, which one is far. This is where most of the time it's usually yellow and gray. But here, with what we call HD color visualization, high definition HD live visualization, nearer structures are shown in yellow. Further structures are shown, or further anatomy is shown in blue. There's also a shadowing effect, as if I have a light source outside, or as if I have a street light outside of the heart. You can see that shadow effect. That also gives me a better depth perception, which is near, which is far. In recent years, there has been a new options such as FlexiLight, where I have a torch effect similar to like a light source inside the heart, like similar to the way we do with endoscopy. You know, so this way it gives us even a better depth and a better shadowing effect. Not necessarily a better depth perception, but a better shadowing effect that also gives us a better depth perception, as in these two examples. Here, for example, you can see this part of the papillary muscle. It looks as if it's attached to the back wall, but when the light source is right on top of it, you can see how far it is from the back wall from the shadow effect that it's producing. This is called FlexiLight, again, an additional tool. It's also helpful. For example, you can position it, for example, here, we are doing mitral valve clip procedure, and you can see the light source is being placed here inside the left atrium. On the right, it is placed inside the left ventricle. We are looking from atrial side on both views. both views are exactly identical. It's just the position of the light source that has changed. You can see when the light source is inside the ventricle and we are looking from the atrial side, you can see the transparency of the mitral valve. You can see in the center, there's no, it is opaque, it's not transparent, not because it's not a calcification, but you can detect calcifications for such patients. But here it is opaque because there is a clip. There's a mitral valve clip already intact or deployed between A2 and P2, of course. There's also additional visualization for the color Doppler, which is called HD color, which makes the low velocities more transparent. As you know, here, for example, in this example, on top, there is an aortic regurg. And you can see when the aortic regurg comes in, the blood that was there gets displaced and swirls around and causing a velocity that is opposite in direction, but giving us false color Doppler. And also it's obscuring the vision of the real regurgitant jet, which is the significant jet, which is the regurgitant jet. And with HD color, we make the low velocities transparent, only the low velocities, we make them transparent, hence maintaining the opacity of the high velocities, which are the significant jets, making it better to visualize. Even, for example, here in this mitral regurg on the bottom, you can see once we activate it, now we can see 3 distinct jets of the mitral regurg, while before activation, we just cannot tell them apart because again, we're visualizing better these significant jets. Then there is also quantification. And of course, what we can do in terms of quantification is for the left ventricular quantification. We can do a lot of quantification, of course, for all the chambers, LV, RV, LA, but that's on a different, that's actually going to be covered on the next week's session, all the advanced quantification. Today, we're only going to talk about LV quantification. And to quickly show, again, here we have a multi-slice type of visualization. This is what the automated tool does when you select, even if you start with a volume, it will go to the multi-slice and it will guide you where to place 2 markers. As you can see here in this video, you just need to place a marker at the annulus and the apex in any of the views. It doesn't have to be the 4 chamber. If you can see it better in 2 or 3 chamber, that's fine. And then speckle tracking will do the endocardial tracing throughout the field of view, not only from the apical 4 or apical 2 or even apical 3, but everything in between, because it has the full volume and it will do speckle tracking tracing of systole in systole, and it will give you a butyl of the actual LV and the instantaneous volume from end-diastole to end-systole and throughout the cardiac cycle. And of course, the volumetric data, diastolic volume, systolic volume, ejection fraction, stroke volume, cardiac output, and so forth. All the hemodynamics. Again, this is how simple and easy. We'll do actually the hands-on in a couple of minutes. And you can see here, because this is a 6-beat volume acquisition, you can see the instantaneous volume from end diastole to end systole. You can see rapid filling during early diastole, diastasis, and then rapid filling again during atrial contraction. This is because it's a 6-beat acquisition. That means the frame rate must be high. I don't see the frame rate here. But it is very high because you can see all these points, all these dots along the graph. That means each one of these dots is a sample rate, as a sample, and that means it's a new volume with a new frame in the frame rate. So again, does it correlate to Simpson biplane? Again, Simpson biplane uses each diameter as an assumed diameter of a cylinder, making it a partial volume of the LV in 4 chamber and then 2 chamber and then the average of the biplane. And this is the actual volume. So in 3D volumic quantification, this is the first time ever we actually measure the volume, because any other method is based on calculations, based on mathematical assumptions that will make calculations that will try to calculate the volume in diastole and the volume in systole. Here we are actually truly measuring the volume of end-diastole and the systole. And literature shows that the end-diastolic volume or the volume measurements from 4D correlate better to the gold standard of volume measurements, which is MRI, CMR, of course. So you always get, when you do 4D LV volumes, you will get higher volumes than you do with a Simpson biplane volume measurement. And then, so it's something to keep in mind. Of course, granted that you have the right 4D data set, and of course, high enough volume rate that you can get high enough sample rate and high enough or accurate enough speckle tracking as well, because speckle tracking requires high volumes, high volume rate or high frame rate in order to be accurate as well.
Very good. C'est-à-dire que voilà.
Is there a question? Okay. All right. So also again, AI tools have been integrated now into the routine eco. There has been lots of new tools relying on AI. Of course, these automatic speckle tracking regions of interest that are being drawn also are part of AI, but there's also additional tools for 2D, for Doppler quantification, AI auto measure, auto AF, of course. AFI also relies, strain imaging relies on AI because it automatically draws the region of interest. There's automatic view recognition. It knows which is 4-chamber, which is 2-chamber, which is 3-chamber automatically. And two of the latest tools that we've added in terms of AI, in terms of integrating it into the routine eco, AI auto measure in 2D. One of the most common measurements, of course, that we do in 2D in every patient, where even if we don't do 4D volume acquisition, even if we do advanced views and T, we always do, for example, Tychel's ejection fraction measurement from a standard 2D image. We used to do it in M mode. Now most societies will tell you it's not enough. You have to do it from 2D because with M mode, the line is here in diastole, but during systole, the same line is actually more basal or more towards the annulus because of the displacement of the annulus during systole. And it could be not perpendicular on all the walls, the septum, the posterior, and so forth. So that's why the recommendation is that you have to do it 2D. But now with AI auto measure 2D, actually, all you have to do is click on auto, and the advanced artificial intelligence algorithm will automatically recognize the end-diastolic frame, the end-systolic frame, and it will also for the LV, for the posterior wall, end-diastole, the ejection fraction, according to Tychel's, according to Cubes, and even the fraction shortening and so forth. Just one touch of a button. The advantage here, the amazing thing is that this is 99% accurate, 100% reproducible. It's I think it saves 85% of the time it takes to do the measurements manually, which we do in every case. Likewise for Doppler, which is even more significant because Doppler is one of the most time-consuming, or Doppler quantification is one of the most time-consuming things that we do in every echo examination. We have to do it for mitral, ENA, E prime. We have to do it for aortic, for LVOT, for aortic VTI. We have to do it for tricuspid, for pulmonic, and so forth. So with AI auto measure with spectrum recognition, for example, if a technician does this study and you want to analyze it, you look at the image, you look at the cursor, you look at the waveform, and then you decide this is LVOT, and then you start on the measurements. You go to Doppler, valvular, aortic valve, you do the LVOT button, and then you do the tracing for all those. Now with AI tools, all you have to do is click measure. AI will do all the rest for you automatically, saving you 93% of the time it takes to do these measurements just by doing the tracing. And depends on how many full ECG cycles you have. You can do anywhere between 1 cycle and even up to 10 cycles simultaneously just by pressing measure. And you can see 98% accurate, 100% reproducible, 3 times less interoperator variability, 93% reduction in time when doing such measurements. So again, we spoke about multi-plane imaging. We spoke about volume imaging, full volume, single beat versus multi-beat, full volume versus biplane zoom prepare. We saw the surface rendering and the automatic volume navigation. We saw multi-slice and flexi-slice, how they are helpful. We saw the quantification. And now I'd like to move on to the EcoPath to show you some of these things I spoke about. But before that, if there are any questions or comments, I'm more than happy to answer, or to if there's anything that I need to go over again, I'm more than happy to do that as well.
السلام عليكم جودة.
وعليكم السلام ورحمة الله.
الله يحفظك. معك دكتور أشرف الخضير.
Thank you, doctor.
الله يحفظك. جودة, you know, there was advice from other colleague that once you come to
But this is created by me. This is created by me, right? But if you acquire with this dropout, then you cannot compensate for it. Then if you try to increase the gain later, it cannot be compensated. It's still not going to be there because the data is not there in the first place. But if you acquire it with a little bit over gain, then it remains there, and you don't lose it if you reduce the gain a little bit later on. Okay. So usually what we do, we say for mitral, you can lower the gain a little bit. But for tricuspid, the gain has to be high. Otherwise, you can notice here, as I'm reducing the gain, the first thing that will drop out are the more thinner membranes. And of course, in this case, between mitral and tricuspid will be dropped out first. Okay. Now, when it comes to color, the problem with high gain of the grayscale, in addition to color, is what we call tissue priority. Because usually, when you have tissue and when you have color Doppler, if the tissue priority is higher, then let me find an acquisition with color Doppler to show you the difference or explain the difference. I think it's a different patient here. Let me show you one. Okay, here's an example for the volume dataset with color. All right, so here you have a 4D volume dataset with color. And if I increase the 2D gain, then you are right, it will obscure the color Doppler. So I can keep it a little high. If I want to remove the color and look at the 2D alone later, I can keep the 2D gain high. If not, then I can keep it low from the beginning, from the start of the acquisition. Okay. However, there is always the function of where is it? Tissue priority. Here, there's a button which is called tissue priority. And this is something with raw data, I can do it even after I store. So I can always reduce tissue priority. If I reduce tissue priority, then I'll have more color. Then the color will be more dominant than the 2D tissue. Okay. Or if I can do vice versa. So if I just want to appreciate the jet better, even if it causes a little bit of quote unquote bleeding, that's fine. I just want to see that and appreciate the jet. Then I can reduce the tissue priority, or I can increase the tissue priority more, especially in the cases in the shunts, for example. Sometimes I need to increase the tissue priority a little bit to avoid overestimating the shunts.
So what do you advise exactly for vena contracta area? What do you advise exactly now? I mean,
try to start with an ideal 2D gain from the beginning. So, for example, here's the mitral. I'm looking at vena contracta. I want to look at vena contracta of the mitral, right? So I don't want to be overgained. Here, this is overgained. Yeah, so I don't want to be overgained. I start with an ideal 2D gain for that specific area. Then I go and activate color. Then this should be the perfect grayscale gain and also color.
So I just missed your advice. Once you come to speak about the 3D with color, you say activate something. Once you, what you should activate in once you acquire 3D with color? Yeah.
Here, when you have 3D with color, there is a button which is called tissue priority. It's just like normal when you have 2D with color. Okay, so if you increase tissue priority, it will make, look at the 2D here, it will make the 2D, the grayscale, more dominant than the color. If you reduce tissue priority, it will make the color Doppler, I'm just jumping quickly, it will make the color Doppler more dominant than the tissue. You can see here, the color Doppler is there's even bleeding of the color Doppler over the tissue. So it's something that you balance between the two. But the beautiful thing here is that you can do this also after the acquisition, because it is part of the raw data. So you can change it even after the acquisition to keep it in the middle, in the optimal zone. So thank you, very good question.
Increase tissue priority.
Yes, yes. Increase tissue priority to reduce the bleeding of the color, to get more confined color. Reduce tissue priority to get more of the color. Any other?
You know,
yes.
Yeah, a few days back, I was trying to acquire full volume with color during TEE. But,
yes.
you know, I face a problem that I cannot, I lose the control of the color box. I cannot control the color box. What is this problem? Why I face that?
Yes, the idea is that the color box, the machine tends to try to make the color box a little bit smaller than the zoom box. So what you want to do, you want to start with a zoom box that is from 4D zoom prepare, that is ideal for this area of interest, for this region of interest. Then when you activate 4D with color, then it will give you the color just a little bit smaller from the 4D volume, the grayscale volume acquisition.
Okay, thank you.
Here in this example, this one has no color, but this is a tricuspid valve, as you can see, right? And we acquired this box right around the tricuspid valve. So if you activate 4D volume color, the box will be, the color box will be just a little bit smaller than this zoomed area. So which is, you know, ideally the color of the tricuspid valve. Yeah.
Okay.
Thank you. Any other question or comment?
Yes, please.
Yes, please.
You can hear me?
Yes, I can hear you.
In Zoom prepare mode,
Yes.
we have high frame rate, but sometimes we have not good details of structures like mitral valve. What we can do for this?
Okay. During the acquisition, when you are on the machine, there's a button that is in the bottom left of the touch screen that says frame rate. So when you acquire multi-beat and or a 4D zoomed acquisition, yes, like you said, you already have the area of interest, you have high frame rate, right? So if the frame rate is too high, higher than you need, what you can do, you can lower the frame rate. This will automatically improve drastically the spatial resolution, the box resolution. So a very good question. Just like 2D imaging, you can always control the frame rate, reduce the frame rate to get better resolution. Or if you're trying to do strain, for example, you need to achieve 80 frames per second, then you can increase the frame rate. So yes, during the acquisition, but this has to be done before you acquire. You cannot do it after. This is a very nice example. This is a 4D zoom prepare. Yeah, that's on the screen. and this is targeting the tricuspid valve, right? So we don't need very high resolution. So what they did here, they lowered the frame rate because such a small area of interest, you should be able to get a very good frame rate. But what they did here, they lowered the frame rate to 10 frames per second. As a result, the resolution is excellent.
Good.
Yeah, so you can see the spatial resolution is excellent. You can see the septal leaflet, posterior leaflet, anterior leaflet, all very nicely.
Thank you.
Yep. Okay. Any question or comment? I'm sorry, doctor, can you repeat that? I cannot hear you well. Okay, so if anyone has any question, next to your icon, you can see there's a mute button. You can unmute yourself. So you can please feel free to stop me anytime and ask any question at any given moment. Okay, so you need to unmute your microphone if you have any question or comment. Okay, so if I may, I will continue now with the yes.
Hi, can I ask a question, please?
Please, by all means.
What are the best settings for LV quantifications, for LV volumes quantifications? The best setting?
Great. I will actually cover that in this hands-on session.
Okay, thank you.
Yeah, thank you. But can we just do the biplane and the multiplane and the Doppler first, and then we'll go through the best LV quantification tool, right?
Okay, thank you.
Okay, so just to go to biplane again, you start with a parasternal long axis. This is using the 4D probe, right? Then you go to multi-D button, and immediately you have biplane. So you can see here the dotted line, and this dotted line, you can control it with the trackball. So if you move this dotted line to the aortic valve, you will get, instead of the short axis, as you can see here, which is at the papillary muscle level, right? You see the short axis is beyond the tip of the leaflet. We're not at mitral valve, we're at papillary muscle almost. And here, when I move the dotted line to the aorta, now my short axis is at the aortic level, or aortic, pulmonic, and tricuspid altogether. Okay. This is with biplane. With triplane, you start with a 4-chamber. As you remember, we said that you need to move the septum a little bit to the left. Then immediately, the moment I activate triplane, I will get a perfect 4-chamber, perfect 2-chamber, perfect 3-chamber. You can see here, if I just rotate this from the top, here the yellow is the 4-chamber. The white, which is the white box here, you can see the perimeter of the white box, or the edges of the white box. This is the 2-chamber. And here the green box, which is the plane in green, and that is the 3-chamber plane. So you can see all 3 planes simultaneously. And look, in between, there is nothing. That means we are only acquiring 1, 2, 3 planes. We are not acquiring a full volume. We're only acquiring triplane. And the frame rate here is 37 frames per second. So for example, what if I want to do strain? Remember, in strain, we need to be 40 to 90, sometimes 50 to 80. I always say, you have to be 50 to 70, or try to always stay at 60, 70 frames per second, right? Because it will never fail. Even if you have tachycardia, you will get good strain if you have 60 to 70 frames per second. So this is something you can do manual by increasing the frame rate or reducing the angle a little bit. You can see here you have maybe a good 5 degrees beyond the lateral wall of the 4-chamber, some 5 degrees here, 5 degrees here. So if you just reduce the angle a little bit, you will be able to get a good LV. Otherwise, you can just increase the frame rate manually, right? Because we're not looking at anatomy, we are just looking at functionality right now. So we just want to achieve that optimum frame rate, which is, I think, achieved in this example here. The frame rate is 50 frames per second. So this should be ideal to do AFI strain for 4-chamber, 2-chamber, 3-chamber, which will not do. This session is going to be more dedicated towards 4D. We've done that during the last week's session with my colleague Joel. So now I will show you a full dataset volume acquisition targeted for LV. And again, you can see here during the acquisition, this is a single plane. Let me look at multi-beat. Yeah. Sorry, my just loop is uploading. Okay, so here I can see 1, 2, 3, 4 cycles, 4 ECG cycles. Okay, with the triggering, you can see it's 4 cycles. My frame rate is 27 frames per second, 28 frames per second. During the volume acquisition, we acquired it the way it's shown, right? You can see the thumbnails. This is the way it was acquired. However, I can still do multi-slice, and I could have done it even before acquisition, because it will give me the same look and feel, right? So I have 4 chamber, 2 chamber, 3 chamber, or the same volume parameters. And I can see, this is why I like multi-slice. Why? Because I can see all my rings of the LV. This is the yellow line where the LV is taken at the apical level. And this is the green line where the LV is taken at the basal level, and the 7 others are equidistance between them. The dotted line in the middle is where the center image is taken here at the mid segments. Okay. What matters here is that multi-slice helps me define lateral wall is within my field of view, lateral wall of the LV. Posterior wall of the LV is within my field of view. Septum, of course, and anterior wall of the LV is within my field of view. And you can ask me, is this also ideal for RV? Yes, I can see the crescent of the RV from the basal segments, again, posterior, 3 wall of the RV, as well as, sorry, let me unzoom this. You can see the whole 3 wall of the RV, as well as the anterior junction between the LV and the RV. So this is ideal acquisition for LV and for RV as well, okay? But for LV, the most important thing are these quote unquote, this 9-pack of donuts. If you have the 9-pack of donuts with no stitching artifact, then you have an ideal acquisition for LV. When will stitching happen? If you're doing multi-beat. Check for stitching during the acquisition. We were doing a course in Cardio Egypt a couple of months ago, and we had one of our global key opinion leaders, and Dr. Kasper Zak, and he said a very nice thing, you know, in the session. He said no patient has ever died from holding their breath, right? So just ask the patient to cooperate if they can, of course, hold their breath for a few seconds so that you can acquire a full volume, and then you can do all the advanced quantifications for LV, for RV, for LA, as well as for left ventricular strain too. This, of course, in terms of transthoracic. If you are doing structural heart procedures, if you're doing introducing devices and so forth, then you need to do single beat because you are doing TE and you don't have that leverage. You want to see everything live. Of course, that's a different story. But in terms of transthoracic, and of course with TE, you're always doing a targeted area, so you can do zoom prepare. So you already have the ideal frame rate and resolution without the need to do multi-beat. But of course, for transthoracic, it's a different story. You need to do multi-beat. So for LV, yes, this is the ideal. You start from the 4-chamber view in 2D, then you choose the large volume. Then you acquire the full LV. This is a targeted acquisition for the RV, actually, not for the LV. You can see the RV apex all the way is being seen. So again, from an LV perspective, the important thing is to capture the 9 crescents, as you can see here. So how does the LV quantification work? You go to measure. You go to volume, and you go to 4D auto left ventricular quantification. Yeah? You can see the aligning is done already. The annulus is here, the apex here. Make sure that the apex, because if the 2-chamber apex is off axis, you will not get a proper 3-chamber, you will not get the proper 4-chamber. So you need to align it properly so that the apex is on top. You can see here, you can change these things as you are going along. You can see my cursor is changing its shape, because here, when I'm in the middle, I can move the entire image sliding. But when I'm on top, I can rotate the top only, or I can rotate pivoting around the center point. Yeah. So this is something that you will learn as you start playing with the images. So what I need to do, I need to go to in diastolic volume. When I clicked in diastolic volume, look at the ECG here. It took me to the R, to the QRS. The image is a bit small. I can zoom it up a little bit. You see the zoom function here. Just zooming, making it a little bit larger. And here, the algorithm is talking to me. In the bottom here, you can see at end diastole, mark apex and mid base in any apical view. So it can be the 4-chamber, 2-chamber, or 3-chamber. I see it well in the 4-chamber. Usually it's easiest to see because you see the annulus insertion. So you know where you need to be at the base and at the apex. So you can start with the base and then the apex, or at the opposite. It's just 2 points, because these 2 points are the most important, because you're deciding the length of the LV and guiding the speckle tracking where to look for the endocardium. Because at the end of the day, speckle tracking is doing most of the work, but you need to guide it. You need to tell it, this is the apex, this is the base, this is where you need to do the speckle tracking. And you can see here the quality check that we will do. You have the reference planes, 4-chamber, 2-chamber, 3-chamber, and you have these 3 short axis views. The yellow dotted line, which is the top one, the white dotted line, which is the image in the middle, and then the green dotted line, which is the more basal. So you have the apical short axis, mid short axis, and basal short axis. So now I can check the quality of the endocardium here from the 4-chamber. Right now my cursor here is on the top on the 4-chamber. You can see this is a bit of trabeculation. I want to include it, right? You want to go to the most compacted endocardium, right? So I make it bigger here. I make it bigger here from the 4-chamber. 3-chamber, likewise, I need to go more compact. Likewise here, the 2-chamber also, I will go to the most compacted, right? So I try to make it bigger. Also in the short axis, I'm looking at the top short axis, which is the basal. Here, for example, I think this should be a little bit higher. That's trabeculation. Here, I should be a little bit higher. So you see, I'm just marking where I think the curve should be, and it will smooth automatically by itself. Yeah. So now I'm done with end diastolic volume. I can go to the next step on the measurement, in systolic volume. And likewise, I need to select a point at the annulus and a point at the apex, or mid base and apex, right? So again, you can see the automatic speckle tracking is done. Still, I'm not happy. I think we need to go to the most compacted, again, endocardium, right? From 4-chamber, from 3-chamber. And if I cannot see it well, I can increase the gain. You can see how much difference it made when I increased the gain, right? Reduce and increase the gain. So from 3-chamber, I think this is not compacted. Here, this is the endocardium. Maybe exaggerated a little bit. Okay. From 2-chamber also, the gain again is too high. From 2-chamber, I do think I need to go a little bit out here, a little bit out here. And you can see even the short axis is agreeing with me. This should be a little bit out. This is more compacted here. So basal 2-chamber needs to be even out. And this is where you will appreciate the difference between 4D volumic information and 2D volumic information. So now I can rely on this more. And you can see the data on the top left corner. In diastolic volume 174, in systolic volume 72 ml, ejection fraction at 59%. And you can click the next button, which is volume waveform, and you will see the instantaneous volume throughout the cardiac cycle. Despite there is 3 ECG cycles, but this is single beat acquisition. There is no triggering on the ECG. This was acquired single beat. The frame rate is only 12.8 frames per second. Yet I have the end-systolic volume, in-systolic volume. Even at this low frame rate, we are distinguishing, or we have a separation between rapid filling during early diastole, diastasis, and rapid filling again during atrial contraction. And of course, if you're using multi-beat, you will see more samples because the frame rate will be much higher and the curve will be much smoother, more realistic, if I may say that. So this is the 4D auto left ventricular quantification. We jumped to it because the question came about it. Any questions or comments about 4D LVQ before we go any further? Keep in mind that during the acquisition and during the initial curve drawing, we tried to make sure that the LVOT is also included in the volume because it is part of the LV volume in both diastole and systole. So I forgot to mention that earlier. Yeah. So when you're happy, of course, we can do all even more advanced things such as the LV mass and 4D strain, but that's also again for next week's session because we'll do more of the quantification next week as well. Questions or comments? Last but not the least, is just a quick recap on the for the auto views. So for example, when I have a full volume acquisition, as in this example, again, it's uploading for a second. Okay, so here I have a full volume acquisition. Here, this button, which is called 4D views. And now we can do the auto align, and that will be the next step. It was done already, so I can just do the apical align manually. Okay, so on the apical align, again, you can see here, now that I moved the 4-chamber view, the dotted line, the white dotted line is not in the right place. This is why I don't have a right 2-chamber. I don't have a right 3-chamber. So when I go to auto align, it will do the aligning automatically. Annulus here in the blue line, top of the apex, the white dotted line in the middle of the 4-chamber, 2-chamber, 3-chamber, we have perfect aligning. Then when I approve this and I go to this crop here, the volume, it is a 4D volume of the heart, but split in half at the level of the 4-chamber view, the familiar 2D 4-chamber view cut plane, and we are seeing half the heart. Now the 4-chamber usually cuts the heart into 2 parts, anterior side and posterior side. So if I rotate it a little bit, I'll be able to easily see this is actually LVOT right behind the cursor, right? So that means this whole half is actually the anterior side of the heart. If I go to flip crop, then I'll see the other half. Then this is the posterior side of the heart. If I go to 2-chamber, again, 2-chamber view or 2-chamber plane separates between lateral and the rest of the heart. Again, if I rotate a little bit, I can see LVOT here. So I know this is all medial. This is actual septum, and behind this, behind the septum is actually the RV. Okay, and I can see my angle here. This is where my eye is. This first half here is all cropped out of the field of view, and I'm looking at this half right here, this medial side of the heart. The lateral side is completely removed from the field of view. So again, this is with automatic cropping, apical long axis. I will crop again with apical long axis. Here, for example, I will appreciate better the LVOT apparatus or the subaortic apparatus, the LVOT, if there's any obstruction and so forth. Then I can also click on mitral valve. Then I have an in fossa of the mitral valve. Look at my arrow here, the yellow arrow, which is right here. I'm not sure if you can see it well on the Zoom menu on the Zoom screen, but you can see the arrow is on the top, pointing downwards, pointing towards the annulus. It means I'm looking from the ventricular side. It means anything above or beyond or more apical from this yellow line is cropped out. So I'm looking in fossa at the mitral valve, and anything beyond the white line here is also removed. That's why when the mitral valve is open, I don't see left atrial wall because it is also removed. So the only part of the tissue that I'm seeing is between these 2 lines here, and that's basically the way it is being cropped. So now I'm looking at in fossa of the mitral valve. Tricuspid valve, I don't see it well. Look at the yellow line. Most of the tricuspid valve is out of my field of view. So can I see it better? Yes. If I go to 2-click crop, here there's a button called 2-click crop. I can say, okay, start my crop above the tricuspid valve and maybe angulate it directly towards the tricuspid valve. Stop. Now you can see perfect tricuspid valve. Little bit of dropout, right? Remember the gain? I can increase the gain. 1, 2, 3. That's it. I don't need any more. Okay. Now look at the mitral valve. There's a noise in front of the mitral valve. Doesn't matter. I'm looking at tricuspid, remember? Tricuspid, I see it perfectly. I see septal leaflet. I see anterior leaflet. I see posterior lateral leaflet. 1, 2, 3. 3 leaflets very nicely. I can also look at the same using flip crop. So here now, I'm looking now the tricuspid is here and the mitral is here. So here tricuspid, this is septal leaflet, right? This is lateral leaflet. Let me zoom it. This is lateral leaflet. And if I flip up, this is anterior leaflet right here. And I can run it frame by frame. Yeah, here. Okay. And in live, again, here is my mitral valve. And here's A1, A2, A3, P1, P2, P3. Of course, I even see it better with flip crop from the ventricular side, but I need to, in order to visualize the mitral, I need to lower my gain again. Lower it 3 steps, the 3 steps that I increased it. Now you can see A1, A2, A3, P1, P2, P3 with some of the chordaes obscuring my vision a little bit. I can bring the translation nearer to make it look even better. Now, when I move the translation, I simply moved the yellow line closer to the mitral valve, hence removing the chordaes from the equation. I'm removing the chordaes. Now I'm looking in fast straight at the mitral valve, A1, A2, A3, P1, P2, P3. That's all I wanted to cover today. I don't want to make it too long for you. I know it's evening in some places and early afternoon, others across the region, and maybe even morning in some other places. So if there are any questions or comments, I'm more than happy to answer them. Let me stop sharing so that I can see the full screen. Are there any questions or comments at this stage?
Yeah, just one question, Jawdat. Do you hear me?
Yes, yes, I hear you.
Yeah. Yeah,
Please.
in case of infective endocarditis, and you would like to see vegetation from the ventricle perspective, okay? Now, what did you advise me just to concentrate on the frame rate or?
No, no. I would focus more on the spatial resolution. I mean, unless if it's a mobile vegetation, then yes, then yes, you need to.
Yes,
yes,
it is mobile.
Sorry. Yeah, then of
yeah,
course you need. Yeah, then it's you need to focus on the frame rate. Of course, that's why 2D and 3D. This is one of the places where frame rate is most important in that aspect. So.
Okay, thank you.
Yeah.
Yep. Can you show us the light source in the examples of the mitral valve?
Sure. Allow me to share my screen again. Okay, so can you see my screen now?
Yes.
Okay. The light source is called Flexi Light, and you can just activate it at any time. And here you can see the position of the light source. So you can see I can change the position. Now I'm in the LVOT and losing it when the mitral is open. And now I move it again towards the posterior leaflet, I move it towards the center, so I can move it also in the right side. Now I'm seeing in front of the tricuspid valve, so you can see the tricuspid valve position very strongly. Once I click, then I fixed the light source. Then I fixed the position of the light source, and I can even add additional lights, so I can have even 2 lights, one in the right side and one in the left side. So now I have a light in the left side and a light in the right side.
The only benefits is that it gives us the true dimensions.
Yes, it gives me better what we call depth perception. Because again, as I mentioned, perception. Yes, yes. Because as I mentioned,
this is the only benefit. So?
Yeah,
right?
Yeah, pretty much. Okay. Yeah, you can also see, for example, transparency if there's calcification, for example, and so forth. So that is another possibility.
Okay, thank you.
Yeah. You can also change the intensity of the light. You can make it brighter, less bright, and so forth. Yeah. And you can turn it off and go back to normal scanning. This is normal 3D, and this is with HD Live. So this is normal, and now I will activate HD Live. Normal will only give me yellow for nearer structures, blue or grayish for further structures. HD Live will give me the same effect with a little bit of shadowing. But the light source is not like the torch. The light source is like an outside source. Yeah. Okay. I call it street light. It's like a street light outside. But the flexi light is like having a torch or a light in my hand inside the chamber or the structure. Yeah. Thank you. Good question.
Hi, Joe. I'd like to ask a question. There's a button
Please.
there, copper blue.
Yes.
What is it for?
This is different colorization. Thank you for also very good question. This is different colorization. Here in this grayscale of the volume surface rendering, we're using color blue, copper blue. So when I click on it, I have different options. I have also, for example, one step higher. Again, it will take a little time to change. This is anatomic 1 and 2. This is called sunset. So it's just changing the grayscale colors, different grayscale colors. This is called sunset. The copper blue is the one that we have selected. It is the default in most of the presets because it's the most eye friendly, I will say, for the majority of people. But again, different people have different color perception also. So this is why we have all these different options as per subjective preference. Yeah. But this is one of the most commonly accepted, and yeah, my pleasure. Thanks. Okay, any other questions or comments? Great. With this, I'm happy to conclude this session. Thank you, everyone, for joining. There are some questions in the chat, I think. Thank you so much. Your tips to get optimal 4D color view. Thank you. I think we answered this a while back. Great. Thank you very much. I appreciate everyone's patience and attendance. And if there are any questions or comments, we are more than happy to answer them. You can also prepare your questions for the next session, which is going to be again next Thursday, same time, which is 3 p.m. Greenwich Mean Time. And thank you again for joining. And hopefully we meet again next week, same time. Thanks.
Thank you very much.
Sophie, you can end the session.
I shall.
Thank you,
Thank
Sophie.
you very much,
Thanks for
everyone.
your efforts.
Have a good evening.
Thanks. Bye-bye.